So now we're going to go ahead and go a little bit further into externalizing disorders with Module 3, and particularly focusing in on how we treat these particular disorders. And so the first thing that we're going to look at is medication, more specifically with psychostimulants for ADHD. So when we talk about a psychostimulant, what we're looking at is a medication that increases central nervous system activity with the idea that it increases alertness, arousal, and attention. So if your symptoms are inattention, this would seem to make sense. It has the most impact on hyperactivity and impulsivity. And what we typically see as a child ages, the hyperactivity and impulsivity tends to decline to some degree compared to the inattention. Though I must say that the impulsivity tends to also still crop up. It's the hyperactivity that we really begin to see kind of the decline in. And usually when children start on these psychostimulants, they tend to stay on them for many years. So I would look at it more of an enhancer to allow people to do pretty well short term. But the research long term is not real promising. It's about as effective as long as you stay on it. And so the minute you kind of go off it, all the symptoms return, which is why it's important, as we'll be talking about in the next few slides, to also have some behavioral kind of therapeutic interventions too. In other words, you can get the psychostimulants to go ahead and provide you some immediate temporary relief, but you need to learn the long-term tools if you're going to be able to successfully deal with some of the symptoms that ADHD provides. Now, the good news is that psychostimulants will improve behavior in about 75% of all the children that take or have ADHD that take medication. So that is an extremely high success rate. And it's one of the reasons that medication is so prevalent with ADHD. Now, the generic name of the psychostimulants that's most common is something called methylphenidate. Most of you have probably heard of the names Ritalin, Dexedrine, Adderall, Concerta. These are all forms of methylphenidate. They're just the commercial terms of that. Now, of course, there are some side effects in regards to any sort of medication we take. So you can see those who are on the psychostimulants kind of decreased appetite, increased heart rate, maybe having some sleep difficulties, and may slow some physical growth, particularly in children. It just depends on the individual about how significant these effects are. But if you can think about it, these are stimulants. They increase and rev you up. And so just like you would with any of the other stimulants out there, when we talked about the substance abuse, there were a lot of stimulants we talked about, you're going to have the same sort of kind of side effects. Fortunately, psychostimulants are prescribed medications and don't have the same dangers as other stimulants like cocaine and other things like that. So there are some alternatives to methylphenidate that are not as well known. There is Strattera or Intuitive. These are norepinephrine reuptake inhibitors, and they are non-stimulants. And so some individuals that the psychostimulants don't work for, that 75%, there's 25% then that means it doesn't work for, may go ahead and end up taking that Intuitive or Strattera, and then that can also be fairly successful. You can see there is an increased popularity of prescription for methylphenidate. Here is the consumption over a 4-year period from 99 to 2003. You can see something happened in Iceland because all of a sudden the daily dosages just skyrocketed in a 4-year period. United States and Canada are awfully high, and you can see in other places in the world the trend in almost all countries is an increase in the use of methylphenidate. But we don't necessarily see the same level of usage. The United States has one of the highest usages in the world. If medications are being overused, there is a fair amount of controversy about that. As you can see here, these go a little bit beyond the prior slide, and you can see the fact that they do vary. You see a lot more kind of uptick in adolescents taking this. And then overall rate has also upticked here when you look at the years between 2005 to 2008. So it's always hard to keep the most up-to-date kind of graphs, but you get the general point of where the trend is going. And then, of course, there's also additional concern about abuse. of methylphenidates in the college populations, as that became a drug of choice for quite a while. Here are the short-term and long-term effects of psychostimulants on both hyperactivity, impulsivity, and inattention. And so you can see the improvements seem to be where there's more work completion, less activity, not as many social problems. But from an academic sense, we're not seeing the grades or standardized test scores necessarily increase as much. I think one of the things that this graph doesn't show is short term. You do see some more consistency in level of work. Those with ADHD might do real well on some standardized tests and then totally tank on others. It's the inconsistency, and it's usually dictated by what they can attend to. When they have more full attention, they do tend to perform a little bit better or more consistent to their performance before. But as you can see, not a lot of demonstrated benefits long term because it's not teaching you new skills on how to deal with things. It's merely just providing you kind of an add-on, and that you need to spend some time focusing on other tool development in addition to medication, so that eventually, if you do go off the medication, that you can still deal with the various symptoms that ADHD has. Okay, so moving from medication, and we aren't going over oppositional defiant disorder or conduct disorder so much when treatments, because medication-wise, there's just a lot of inconsistency compared to what we see with ADHD. So when we talk about more treatment of externalizing disorders, we do have behavioral family therapy, and this may be used for oppositional defiant disorder, though it's been used with other types of disorders because obviously there are a lot of typical components for behavior family therapy that could be very helpful for a range of externalizing kind of disorders. So what behavioral family therapy does is it teaches parents to be clear and specific about the expectations for children's behavior and to monitor children's activities very closely and systematically reward the positive behaviors while ignoring or mildly punishing misbehavior. So in other words, kind of avoiding that coercion trap that we talked about in the last module. Typically, what we're going to see is that these begin with a parent training component. Parents are taught to identify specific problematic behaviors, like arguing with siblings. And then they're supposed to list preferred alternative behaviors, like speaking nicely as opposed to, give me that. And then set consequences for inappropriate behavior. Consequences are very important when we have this. And part of this training is really teaching parents about parent punishment strategies like timeout as opposed to yelling or using corporal punishment, which looks like spanking. The goal is really to teach more authoritative parenting. So when we talked in Module 2 about the various parenting styles and those that are successful for externalizing disorders, authoritative parenting was one of the key ones. Short term, we know that this is a pretty effective approach, and that parent training can be delivered in a variety of modalities. You can do it in groups, you can do it to parents of toddlers, and you can even teach some of these techniques through kind of mass media. So a very flexible approach, education kind of related and more structured in that way. Now, the treatment or long-term effectiveness of behavioral family therapy is not as certain. Benefits are generally limited to children under the age of 12. So you're not going to do behavioral family therapy for 15-year-olds. It's a little bit too late for that particular approach. You got to try something a little bit different. The good news is with oppositional defiance, activities like behavioral family therapy can make some differences. Not so much with conduct disorder. Conduct disorder among adolescents is even more resistant to treatment than a lot of other externalizing problems among younger children. And so the one thing that looks the most promising is a multisystemic kind of therapy. And what this does is it combines family treatment with coordinated interventions in other important contexts of the child's life. So this could include peer groups, schools, neighborhoods, and really has all of those systems kind of working together, giving the same sort of message. And when that happens, you've seen a lot better outcomes than the other approaches, or any of these approaches kind of broken up into just a single setting. There are a couple of other different approaches. You have residential programs. That's where the child with the conduct disorder actually lives in that setting. And it can be very effective as long as they're living in the treatment setting. But as soon as they get out, you see a very high recidivism rate once they leave, because they're going back to the exact environment that really spawned the original behaviors. Juvenile courts, you really aren't going to see a whole lot of change of behavior in that, and that's been one of the frustrating things. So you can't just put them in jail and imagine they're going to come out reformed, even though that was the original intent long ago of juvenile courts. So that's going to wrap up our discussion of externalizing disorders. We've talked about the general characteristics and specific disorders that usually land under this category. We also have talked about some of the frequency and causes, and then this module focused on treatment. So in module 4, what we're going to focus on then is the opposite, and the other category we talked about in module 1, which is internalizing disorders.